I'd like to start reading.
Yeah.
One of that was not. Yeah.
Okay, good morning, councillors, officers and viewing public. Welcome to this meeting on the Public Social Care Overview and Scrutiny Committee, which is also my first as chair of this committee. I will inform you of changes to committee membership and joint tasks under the other urgent business. May I remind members that this meeting will be webcast for live and subsequently broadcast by the council's meeting YouTube site. That members of the press public may record and take photographs except where there are confidential or exempt items. Just need to remind members that the speakers and the microphone are at the far end of the room, so we need to make sure when we're addressing the room that we're actually speaking clearly. Can I ask members of the scrutiny office if there have been any apologies received?
We've had apologies for the next Paul Hillsley.
Okay, right. Thank you for that. Declaration of interest. Do we have any members, any interest they wish to declare regarding today's meeting? No. Thank you. Action notes and matters arising. Are members happy to agree the action notes are an accurate reflection of the meeting? Please. Agree? Yeah. Okay. My understanding of the matters arising from the meeting are on page 4 that they regarding the update on the Children's Public Health Commission Health Services. This information was circulated to the committee on the 29th of July. Regarding page 6, that the information from Dr. Anna Gray, consultant in public health, was circulated on the 10th of August. Page 7, update on the reopening of the day centres. Information on the vaccine status of the workforce in day centres was circulated on the 2nd of September. And finally, the Health Watch annual report for 2020-21 was circulated on the 23rd of July. And then there's a note down here that the Health Watch site loss report was circulated on the 6th of August. Are people, members actually receive those? As far as they're aware? Okay, so the first thing we have is the tracking report on the period of poverty and raising period awareness. I understand Dr. Marion Gibbon will present the tracking report for us to consider.
Indeed.
Over to you. Thank you for attending.
Thank you very much. It's quite a surprise this morning to realise, oh, I've got to get into BMI. But in terms of, this has been quite problematic in that it was originally with a different Assistant Director of Public Health. Elizabeth Grunches was originally the officer responsible for this paper, and on her leaving, it was then decided that the children's lead would take on this. And Jo Bradley is on leave at the moment, so I said to her that I will present on her behalf. And so it's been a bit of a challenge for us in terms of ensuring that we were really conversant with all the different elements and who was doing which parts of this. And I feel now that we have got a grip, which, so even though we're not going to be we're not agreeing because of all the things that are happening, I know exactly what's happening, and I am able to assure you that we will be getting this back on track. So in terms of a paper regarding the pledge, there was a discussion, and the Birmingham City Council are in the process of reviewing the family-friendly offering. And as part of that review, it's been identified that further workplace guidance needs to be issued. And so this will be one of the pieces of work that we will be taking forward. In addition, the Menopause Support Forum, under the umbrella of the Diversity Alliance Network, have been discussing menstrual well-being in the workplace and how periods change during perimenopause. And moving forward, the newly established Equalities and Cohesion team within the Partnerships in Sites and Prevention Directorate are going to be working very much more closely with the staff network groups, including Menopause Support Forum, the LGBT plus the network and health well-being within the organisation as well. And all of this is going to tie in with the work under New Ways of Working. And once the cohesion team is fully recruited to, this work will then commence with the partner organisations and local small and medium enterprises, especially with where there's female employees on with low pay, because this is particularly the concern that we have is around those that are in poverty and yet working, and the stigma that's attached to all of that. And what we are also anticipating that we're going to work more closely with the West Midlands Combined Authority Thrive at Work programme to ensure that in future queer poverty is a consideration for their workplace health and well-being accreditation. With regard to number 3, we are looking at the feasibility of commissioning a research programme for this topic at the moment, and looking at it within the cultural attitudes piece of work that we're undertaking with our community researchers, and looking at how we can really understand more about period awareness from the different communities' point of view across Birmingham. We've recently been awarded some NIH, our National Institute for Health Services research funding, for me to have half a day a week on research, and two further members of the public health team. So we will have some actual concerted time in order to promote research. So it will be under that part of that agenda that we take that forward. In terms of number 4, the work that's with the voluntary sector, they're continuing to provide some location for donated products, and it continues that there's work going on to ensure that all the food banks have menstrual products available for those who attend those. But we're kind of looking at further things that we might be able to do around that, making sure that homeless people, homeless women, or also, and those in temporary accommodation will be supported as well. Then number 5 is where a service is commissioned by the City Council, the possibility of including a clause about alleviating period poverty and raising period awareness should be considered in all future contracts, and that is going to be undertaken through our commissioning partners. And the current chapter guidance is going to be updated to include a reference to period poverty and how businesses can support the agenda by awareness raising and practical actions. And there's going to be a team social value channel which will be able to be used to inform commissioning and procurement colleagues to consider where it's relevant to include period poverty as a specific area of attention in their social value specification. And then the rest of the points, I think, were all completed.
Thank you, Dr. Gibbons, for that. That's really appreciated. Members, can I ask if anybody have any questions they want to ask? Councillor, yes?
Thank you, Chair. Thank you, Doctor. I think it's nice that you've given an overview because, to be honest, I'm relatively new to the committee, but I do remember the motion when it first came to council. I think when I looked at it last night, just to double check, we're going back to that first motion in December 2018, and then to agree the recommendations, members might remember that it actually went to council again on November 2019. It's a little disappointing because when you look, we are, not that far off from 2022. And I do remember at the time, not trying to backtrack, but there was some passion around the subject within council. And it was quite an emotive topic for people. Some shy away from the topic, many don't. For obvious reasons, females, they're hidden from us. If they did watch the council meeting, probably thought, great, because I struggle, and we all know the cost of it. It's quite harrowing, really. I'm glad you talked about the cohesion team, because I was a little bit unsure what it meant before, why that would really gain traction. Procurement, an interesting one. Not sure how that will pan out, because we have issues in the council with contracts anyway. And I think, if I've got this right, from looking at some contracts before, there's a social element to that, sort of corporate social responsibility. So I don't know how you will gain traction with that, and I certainly hope the officers can propel that forward, because it needs doing. The recommendations that I've got here in front of me, there are obviously 3 number 4s and 1 number 5. And I know that COVID is some of that. But as I say, the timeline it's a bit disheartening, really, that we can't just fall into a trap of, well, the staff, we're changing, we're transitioning, and then find ourselves in another year to 2 years in the same situation. So I do hope, really, that the seriousness of which it was discussed in council is really taken forward and not on the back shelf. I just want to mention one thing, because in the report it talks about violence under quiet conditions, and it sort of says that this wasn't really looked at in the report.
Yeah,
and I think it was expected to be.
well,
So
I will. It wasn't looked at.
Page
no.
6.
Yes,
of
indeed.
7.
So what has been now undertaken is there has been a report undertaken by Thea Racebeck, who's an honorary research fellow at the University of Birmingham. And what I'm going to do is explore with her how we can make sure that her findings are turned into recommendations, and make sure that they're actioned with the appropriate partners over the next few months. It's been quite a challenge for me in terms of making sure that I'm really conversant with all the elements of this, because it hasn't been straightforward in that the person who was leading the work disappeared, as well as there being COVID. And so I'm now really able to say that I am fully conversant with this area of work, and will make sure that it is kept on our agenda, and ensure that my team member who's got this area and within her portfolio is has your comments go back to her, and so that she's aware also of the importance that you place upon it too.
Thank you. Any mental questions? Councillor Idris?
Thanks, Chair. Reading poverty and creating the awareness about it and the stigmas attached to it, I think maybe the key is the schools, particularly the secondary schools and possibly colleges. So what work is being done through the schools and colleges?
The schools do have a programme, but what I can do is make sure that as part of their PHSE programme, if menstruation is covered there. I'm not sure to the extent what period poverty is covered within that curriculum, but what I can assure you, Councillor Idris, is that I will ascertain that and find out and be able to report that back to you.
Thank
you. Okay, thank you. Thank you for the answer to that, Dr. David. Councillor Fallon.
Thank you, Chair, and congratulations on your post as Chair.
Thank you.
Yes, in no particular order, excuse me, I'd very much like welcome Councillor Clancy about the quality of the team on board. I noticed as well that the draft of the new offering, including manager guidance, etc., is awaiting cabinet approval. I'm not sure you mentioned whether that's taken place or not. And welcome as well that as a member actually of the combined authority that it's working in partnership with. So very much pleased with that. I'd also like to offer my thanks as well. I'm sure everybody else will, in particular about the third year student who actually did some additional work on that. And I think that was to be commended. That person took some extra work on. Councillor Clancy has already mentioned about the violence thing, so part of it, so I'm happy and content with that, as with Councillor Idris on the schools. The other one that still I didn't see an awful lot of, and members will know, especially with my shadow portfolio position as social inclusion, community safety and equalities, I'm still eagerly looking at, and it's called cultural attitude and the potential of moving that forward. Because I'm often told, Chairman, that it can be a bit of a taboo subject within the ethnic communities, but I'm having ethnic people or people from the ethnic communities say it needs to be brought forward. And I can't see any evidence in here of how we can take that cultural attitude forward for the ladies of all race, colour and creed to make it more prominent. Because there is still, from what I understand, Chairman, there is still fear out there and concern from young ladies of all ages, obviously, having menstrual periods and of all colours. So I just really want to see that taken forward, so I can actually see in our diverse city that there is action being taken. Thank you.
Okay. As I mentioned, we have now been training some community researchers, and their first piece of work has been around looking at cultural competence, particularly of professionals, regarding the way they interact with people from our minority community. And what we are proposing is that a third piece of work with them will be around period poverty, because it's much easier to have conversations where the person who is doing the questioning is from the same community as they are, so that will overcome some of the difficulties and that might ensue from somebody of the different ethnic group being talking to. So that's the proposal for that, and we would hope that we'll be able to report. But and I think I did actually suggest that action we would look to having in place by February 2022. In order, because in time it takes to do a piece of research with our community groups, it's not exactly the most speedy, because the final group has not been finished their training. 2 months to get that piece of work completed.
Chair, can I thank you very much indeed for that additional information. That's very helpful. And certainly, Councillor Clancy, we all have this very much in our hearts and minds on this. And yes, the quicker we can get this moved forward. I know there's been the pandemic, but we really need to have time like this. I mean, it's a big important issue, and speed it along if we can.
Yes, sir.
I'm very grateful. Thank you.
Thank you, Councillor Fowler, for flagging those issues up for me. Councillor Pocock is the next person who wants to speak.
Yes, thanks, Chair, and again, congratulations on your new post of office.
Thank you.
I'm sure you do a very good job. First thing to say, I think, is that you recognise the difficulties of the pandemic, and I've got to say this landed on the shoulders of our department in unprecedented periods. Let's understand that this has had to take second place to other priorities. So I think we recognise that point. Nevertheless, it's good to see the way is now clear for progress. And my first question really is about the National Institute of Health Research. You said is now available, and how this is going to help. I think I've got 2 questions.
Yes, certainly. Yes, okay.
One, can you tell us a bit more about that, and what your role will be, and how this might then help play catch up on this project. The second angle, Councillor Fowler has touched on it. The report started with a focus on period poverty. It developed into also a recognition of problems of period awareness, particularly young girls as they come into the menstrual cycle, but equally that men and boys need to be as aware as women and girls about this issue. So I'm keen to see how you might be able to take forward the inclusiveness on gender as well as ethnicity. Councillor Fowler's raised the issue of ethnicity, but I know that the issue for men and boys is equally important. We all stood up when we presented this report and declared our support for the Girl Guiding Pledge, which says we all, men, women, boys, girls, talk openly and in a relaxed way about periods and menstrual cycle, which is, I think the report was presented by 3 blokes, real blokes, or Peter Fowler's case maybe young to middle-aged. To make the point, it's an issue for men as well as women. So I'm keen to hear how you might be pursuing this issue with men and boys too.
Thank you. I fully recognise the points that you're making, and in terms of the NIHR funding that's been made available, I have been awarded time for half a day a week for the preceding following year, and also there are 2 officers who've been awarded a similar amount of time to spend on promoting research across the organisation. We're also hoping to utilise that time to get further funding and be able to make sure that we can do more research across the whole of the council, not just having public health officers involved in research. I would like to see all the departments involved in research or at least evaluation as well. So that's the NHR one. And I know that a plan was developed in the schools around ensuring that teachers and students are educated about period poverty. And I would like to go back to that piece of work and see if that plan incorporates what you're suggesting as well. Because I think this piece of work could be undertaken through the schools more easily than anywhere else. And so that we do involve both girls and boys in secondary schools in conversations to do with menstruation. And so that would be my suggestion around that particular point. And so even though we've got a tracking assessment, which is good for that particular point, I would like to find out a bit more about what that plan consists of and whether we could build upon it.
Suggestion, when we do have the next tracker report, you could bring that point out.
That'd be really useful. Thank you for that, Councillor.
Councillor, thank you, Chair. It just for clarification, I don't understand this thing. It mentioned about the cohesion team, the page 4, bottom paragraph, has mentioned about the employing significant numbers of female employees in low-wage sector on how to tackle real poverty and stigma within the city. So about the employing, the low-paid sector, I don't understand about this. Can you explain about, how it works about the female employee, low-paid employee or something?
I think one of the concerns, particularly, is as has been mentioned previously by other members, is because of the price of these products being quite very much higher in comparison. So if you're poor, to buy menstrual products is quite a challenge. And so that is the element that we need to make sure that we're addressing. And it's furthermore, it's to do with that, all this, the difficulty it sometimes is around talking about these topics. They are sensitive topics. Sometimes women don't feel comfortable talking about menstruation or period pains. If their line manager is male, they want to be able to talk to somebody who's female. They want to be able to make sure that they can, if they're having particular problems with menstruation, that they speak to a female doctor rather than a male one. So it's those kind of elements that we need to make sure we're addressing.
Thank you.
Okay, thank you, Dr. Gibb. I've got a couple of questions myself to sort of tie things up here, hopefully. One's quite a brief one. There's a notification that you're going to have a couple of paediatric specialist trainees during Are they actually on board now?
They're joining us this month. Yes, but they're not on board yet, but they will be.
And they're going to be hopefully for you.
Yes, indeed.
Yeah, that's great. And on point 4, if you could expand a bit in terms of how period poverty and awareness has been addressed across home services. That's an issue I have a lot of contact with in my non-council.
Okay, and so it's been a lot of the work has been done through the voluntary sector partnership, but I'm also doing some work with Steve and Phil Potts regarding some of the work that we've got concerning homelessness and mortality. And so it's one of the topics that we're working together on, making sure that we address issues to do with our life course, and therefore that it comes into that area.
Okay, have you any timescales in terms of when you're going to be expecting to be able to provide a more upgraded service or a more joined up service in terms of accessing period products? If I'm going to be reporting back in February 2022 from what's been agreed so far, can I make sure that I address that and bring it back to you at that point in time? Yeah. Okay. As long as we pick it up at that time, that would be fine. Does anybody else have any other questions?
Chair, sorry, my apologies if you mentioned this, I picked it up. So I mentioned about the draft of the new offer that would go into the cabinet portfolio. Has she seen that, and when will we get?
I haven't seen it yet myself.
Right.
So I would assume therefore that it hasn't gone to our cabinet member, because I would need to see that, and then I would be able to address the timescale on that. I haven't seen that report yet.
Chair, we're very close to know when that's going to, and when we will have the possibility to look at it for examination ourselves. My other question was is slightly separate to that. I noticed in the report about where you can pick products up from the food banks. Is that what's being given to the food banks, or is there an opportunity, and I guess there is, for people who may wish to donate?
Yes, there's definitely a possibility of people wanting to donate products.
I just wondered how we could get that message out to, because there may be a lot of the ladies that might just say, I would like to offer donate to help young ladies. And
what I can do is address that with our comms.
Thank you.
And that will hopefully will make sure we tie all these loose ends up.
Yes, and obviously we can look at that when you report back in February, but possibly if you're able to send a note through, just so you can just update in terms of how things are progressing.
Yeah, sure, no, definitely.
Thank you, Chair.
Yeah,
Does anybody else have any questions? Which brings us to the point then, as we need to make a decision in terms of whether we're going to be agreeing or not the cabinet members' assessment. Or we may have reservations about the speed of it, in terms of the principle thing.
Can I just clarify? So we talked about the report coming back to this committee in February. So I think on the strength of the discussion today, all the recommendations would be coming back to your February for a further update. If members are agreed with that, we'll programme that in.
Yeah.
Okay. Do you agree with that?
Yeah.
Thank you. And thank you, Dr. Gibbons, for something to say. Appreciate it.
Thank you, Doctor.
Thank you.
Okay, thank you. Thank you, Commissioner. We now come on to number 6, which is the adult social care performance monitoring for Q1. I understand that John Williams is on the screen already, and he's going to be presenting the report remotely by Teams. And then when John's finished the report, we'll be inviting members to ask questions. So, John, to give us your report.
Thank you very much, Chair, and thank you for inviting me along. I'd like to give apologies for Maria Gavin, the Assistant Director, who normally reports on this subject. She's on annual leave, so I've been asked to step in. The quarterly report for adult social care covers April to June 2021, and it's just important for us to note that, even though we're in late September. The first part of the report, and you've got the pack with all the details in, Chair, but I wanted to highlight the red exceptional areas for adult social care. So the first part of that is the citizens that we've reviewed within a 12-month period. Our performance target is 85%, and as of quarter one, the end of quarter one, we're at 76.4%. So what we recognise is we still have work to do to achieve that 85%. What's important to note is the context and impact of COVID on adult social care assessment teams, where we have had to refocus our social work assessment time into working with some of our most vulnerable citizens. This has meant that some citizens have been seen 2, 3, 4 times during that 12-month period in order to make sure that they are safe, well, and we are providing the service that we need to. From a performance point of view, we only capture one of those visits on our 12-month reviews, though. So that means the other 3 visits are the right thing for us to do. They're important for our social workers to go and see our citizens and our carers, but we do not capture the performance linked to that. What we've recognised is there's significant work for our teams to do. So there's a new performance framework being put in around our reviews. This is meaning that our teams are targeting our reviews on an 11-month year. So what we'd seen previously is that when we got to March of each year, we would have a significant number of reviews that were outstanding, and we have tried to bring that into and have that phased over the entire year to make it easier for our staff, and also to reduce our reliance on agency and temporary workers in the last part of the financial year. In addition to that, some of our teams are better at reviews than others, and some of that links back to the level of retention of our social workers, also the complexities of people living within those areas. So there's a piece of work going on at the moment with Ladywood and Perrybar, really to understand the impact, especially in relation to complexity, poverty and deprivation, and support our team managers and our social workers to then be able to then work with our citizens in the most appropriate way, but also then seek mutual aid from other parts of our system, so both health and social care and housing. Chair, before I move on, would you like to ask any questions about reviews?
Yes, Councillor Pocock.
Yes, thanks, Chair. Just two things. To be clear, it's this issue that we've hit is where people have had 2 assessments during the year, the second one being provoked by COVID. And as a result, despite they've had 2 assessments, it only kind of counts once in the percentage of people who have had a review in the last 12 months, which is why we're at 75%. First, just for clarification. Secondly, what do we know about the 25% who've not had a review? Is there anything distinctive about them that we could understand as to why they haven't been reviewed? Is there particularly difficult to access these people? Is it random? So I'm interested in the characteristics of the 25% who not had a review, and whether inadvertently there may be some inequality emerging in that.
Yeah, so the first part, Councillor Pocock, is yes, you're correct. So when we review individuals, we review them once, and that's captured on our performance matrix. Any subsequent review or reassessment is then not counted from a performance point of view. So what that means is our social work time is taken up. So we look at our citizens, we work out how many reviews each team can do, and then the unscheduled reviews or reassessments that come in during the month then impact on those figures. And our team managers, our heads of service, have to make very pragmatic decisions around what they do with the reviews for that month. So that may mean 10% of the reviews that were due in April would then move back into May. And what we see is that then pushing of reviews back throughout the year. This is where in subsequent years we've got to March, and between the 1st of March and the end of the month, we've then had this almost glut and sort of a bubble in our system. That means that we have twice as many reviews to complete during that period. That then means subsequent years come, then that person is due a review during that March period, and that's why we're trying to bring them forward to ease the pressure on our social work teams, but also we recognise as we get into winter, our social workers have got to prioritise the hospital discharge and the impact of winter as opposed to doing the schedule reviews. The second question you asked in relation to people not being reviewed, what we have is a rolling rota. So what will happen is if you're due a review in April and that doesn't happen, we will then review you in May. So people may not be reviewed within the 12 months, but they may be reviewed within 13 to 14 months at a maximum. So we're still seeing as many citizens as we can, and we're still making sure that we work with people that are at a significant risk. So those that we know that have got elderly carers, people living on their own, and low packages of care, our team managers will take a risk-assessed approach to who we need to see. Those that have got residential care and significant wraparound packages of care, we then look at a lower risk because they've got significant professional support going in who normally flag when there's an issue.
Does anybody else want to ask a question on the reviews?
Yeah.
Adrian?
Thanks, Chair. In terms of social workers, and going back a few years, we had a lot of social workers leaving the service for one reason or the other. Since then, have we got enough welfare and social workers replacing those who have left?
Thank you, Councillor. There's a significant piece of work going on at the moment with the senior management team and also our HR colleagues and finance in relation to social work retention. What we see is social workers will move across local authorities and also look at promotions and think about, is it the right career for them? So some of our social workers will go and move into health. From a social care point of view, we have enough social workers to do the work that we need to do, with one or two exceptions in some of the teams where the work is significantly complex and where we need very complex and significant experience to manage those cases. So that's where we then see some retention and recruitment issues. We've got a plan at the moment, which means that we will help and support our teams around mutual aid. So if a team, and we've looked at this recently in relation to our outstanding allocations, if a team requires support, then we will bring that in from different parts of our system. So that may be that our health colleagues work closer with us, or that we bring in some additional capacity. And also we work with Hayes as a recruitment agency around short-term capacity as well.
Thank you. Anybody else got a question? Councillor Clancy?
Thank you, Chair. John, following on from what you've just said, can I just ask you what the case workload now is for social workers? Back in the day, when I first started, the rates were high. And I know there was a lot of work done back in 2016-17, really to try and get that reduced. So if you're able to say on screen, being public, if you can't, that's fine. But I just wondered what the case rate was now per social worker. I know there's complex needs and they'll have different responsibilities, but I just wondered what the average was.
Thank you, Councillor Clancy. We work on the average between 15 and 20. 15 to 20 cases per social worker. Now, what we also recognise is that some of our colleagues will work with very complex individuals, and so therefore their caseload, in discussion with their senior prac and team manager, is reduced to enable them the time they need to work with those complex individuals. In addition to that, social workers should see a mix of complexity and non-complex cases to make sure that we're then able to support their well-being. Because what we don't want to do is burn out our social workers just because we keep giving them lots of complex cases. Our team managers are very good at case distribution.
Okay, that's great. And are they still on the Care First system, or have they upgraded the systems now? Where, because it was quite clunky before, I remember that, and I don't know whether that's been updated now for social workers to streamline the information that was going between departments to get cases and reviews and assessments seen quicker.
Yeah, so there's been significant work over the past 2 years really around that, as you say, that burden of bureaucracy and handoffs, and then we're working very closely with the principal social worker, team managers and heads of service. We are still using the Care First 6 system, and that's being phased out, and we'll be moving on to Eclipse, which brings us in line with the Children's Trust in 2022, and that in itself will help with some of those handoffs as well.
And very briefly, is in your opinion the three conversations model working? Because that was obviously a big strategy that the council were moving forward. So I don't know if you've got a comment to make on that. And just on the end of that, looking at the budgets, John, for the last couple of years, there has been an underspend on the budget. Do you see that changing? Do you see that tide on that underspend changing as a result post-COVID? Now, with what we're looking at today in the monitoring.
Right. Councillor Clancy, could you just ask your first question again, please?
Three conversations model.
Yeah. So three conversations is well embedded. I believe as an asset-based approach, it works extremely well. During the summer months, we've also had a peer review from West Midlands ADA, so the Association of Directors of Adult Social Services, which seen Free Conversations as being a very forward-thinking system, and that Birmingham City Council is then probably leading the way nationally within that regard. That links back to the budget question that you've asked, in that the Free Conversations very much brings a opportunity to help people with resilience and independence, and reduces the short term. So we have a diversion rate of approximately 50 to 60 weeks. So that is a citizen asking for help and support, working with Free Conversations, the NNS network, the voluntary sector, faith sector. We're able to offer different opportunities for them before we require to put care and support in. So that in itself helps us manage the budget. Our colleagues in finance and the adult social care management team are currently looking at the future projections in relation to the budget to understand the impact of COVID. What we recognise, which is seen also with our health colleagues, is lots of people have been reluctant to ask for help and support. And so when they're then coming to us now, they may be in a different place to what they were 6 months ago or 12 months ago. And our social workers are working very closely with them and also their family and friends.
Thank you, John.
Thank you for that, John. A couple of questions on that. With the reviews, how are they actually undertaken? Do you take them by phone, or do you take them face to face, or do you use a variety of ways?
Yeah, thank you, Councillor. Yeah, there's a variety of ways we're doing reviews. So some of those are face to face, especially with those with communication issues. For example, hearing impairment, complex dementia, learning disabilities. Other reviews we're able to complete via a phone, especially when we've got really good links with the individual, and some people prefer that contact. There's also been a reluctance from some of our citizens to allow people to come into their home during COVID because of the fear factor that brings. And then also we're starting to get into more video conferencing. So we're using Teams as a way of then being able to do a virtual review as well. It is very much around the needs of the individual, and our social workers are moving back into more face-to-face contact. Some of the work that we'll be doing going forward, we'll be working with our health colleagues in relation to where we can go into a GP surgery, a health centre, and use some of their facilities, so we can then enable people to connect with us in a different way.
Would it be right to assume that if I have a visual impairment or a hearing impairment, or I just a dislike of using IT, that I would be entitled to have my review done physically, face to face?
Yeah. That's correct, Chair. Yes.
Okay. Then the second question is, I remember from a while, possibly 12 months or more ago, that there was an issue in terms of getting the review figures up they needed to be. So I suppose I'm considered. Oh, you said there's teams now to account in monthly meetings for heads of service that they're actually targets. So am I correct to assume you've got a outline performance management program in place here to try to get the figures from where they currently are to where they need to be?
We have, Chair, and that work's been going on for quite some time now. I believe if we hadn't had the impact of COVID, then we would be achieving our target now. What we've had to do over the period of COVID is redirect our colleagues, our social workers, to making welfare calls, connecting with people that need multiple assessments. That in itself has impacted on our workforce, on our ability to see everyone that we wanted to see. And that's the same across other local authorities across the West Midlands too.
Yeah. Okay. Thank you for that, John. Anybody else any questions? Councillor Tower.
Thank you, Chair. Hi, John. Good to see you again. John, first of all, I'm very grateful that through former Chair, Councillor Pocock, we managed to get the reds more prominent at the top of the report, which has helped us to identify that, and that I'm very grateful for. Of course, I do appreciate that Q1, April to June, and we're just coming to the end of Q2 now, which would be the end of to the end of September. I did notice that with the reds, we actually had now got highlight measures, and I noticed that shared lives that I thought perhaps should have been in the red, because it is on red, but was actually shown under highlights. I wonder if that could be explained why that wasn't up in the reds as well, and why we got the highlights is another question. What I'd also like to say, and I have said where we could, and the Chair's probably alluded to that, although we have to wait 3 months for these reports, which by the time we do get them are usually almost out of date. So I'm assuming that, and hopefully that the targets actually may have improved by the end of September. And the other point is, early intervention. Do we know when we're going to start to see feedbacks, a report from the early intervention, which we actually highlighted as one of our top measures? And I see always on the performances we get what happened, what we are doing, but the one, Chair, that I would still love to see is outcomes. But I don't get to see the outcomes, which is part of what I mentioned when we were looking at the red, highlighting the red, and then you come back and say, what's happening, this is what we're doing, and this is the outcomes of that. But I would like to see more evidence of the outcomes, if I could, please, John. Thank you.
Okay. Councillor Fowler, if it's okay, a lot of questions you just asked, I can probably go through as I go through the rest of this report once I move from reviews, if that's okay with you.
Lovely, John, thank you.
So, Chair, is it okay if I carry on?
Yes, please, yeah.
So the next red indicator for adult social care is then, as Councillor Fowler mentioned, is shared lives. We have a stretch target for our service of 140 at the moment, and as we see, we're on 106 within Q1, which is our slow progress as we move forward. There's some work going on at the moment in relation to the number of referrals that we send to shared lives, the recruitment of carers, but that will take between 3 to 6 months per carer as they go through a very rigorous recruitment process, which is similar to that of a foster carer. And also, in addition to that, then the expansion of the service internally, so we can then support those carers as they come online. We had been for quite some time below 100 carers, and so I think it was noted in the last overview scrutiny the work that our colleagues had done and the progress they had made. And what we need to do is just keep capitalising on that work. We also recognise that from a care market point of view, that we've got a number of people that are coming out of the profession who are doing direct care for one reason, who are then approaching us in relation to becoming a shared lives carer. So some of the work that we're doing with our internal teams and our external partners, so Shared Lives Plus, is about really building our portfolio to try and make it so shared lives is easier to access, a better alternative for our citizens, and a wraparound support for our carers that work very closely with our most vulnerable citizens. The direction of travel is going in the right way, as I say, so we're improving each month, but there sometimes is a glitch where a carer may decide to retire, and that then brings our figures back down, but we are still targeting that 140. Chair, would you like to ask any questions in relation to shared lives?
Can I just say something, John? It was really good to hear all the members getting involved in the discussion regarding the reviews, but it's took a fair amount of our time. So what we may want to do is possibly you go through the report and then we save the questions until the very end if people are happy to do that. Yes. Yeah. So do you want to carry the report, John, and then we'll come to the questions at the end?
Yeah, so what we had said, we would highlight the red areas, and that was then shared lives and also the reviews, and that's where we felt that we needed to have more discussion. Within the report, what you'll see is the long-term admissions, so that is a green and heading in the right way, and that is very much around sort of reducing the number of people in residential and nursing placement. Our direct payments are number at the moment, and at the end of Q1 they were at 38.4%. This is a significant focus of the directorate, and what we want to see is really how we keep pushing direct payments, especially as we come out of COVID. The early intervention, and Councillor Fowler asked this question as well, we are looking to bring updates. I think it was October time, if I recall a previous report. That's when we'll be looking at the metrics for that, and I believe my colleague Amanda Jones will be on the call soon to talk about early intervention and hospital discharge and our impact and outcomes for citizens. The scorecard itself provides an overview of all the work that we're doing, and as you can see from that, we've got significant greens, some work to do in ambers, and the reds that we have discussed, which is then shared lives and also the reviews. Thank you, Chair.
Thank you. Anybody else any questions you want to feed through? Okay, well, I got a couple myself. In terms of the shared lives, you made a notation on page 19, I think, that there's a briefing paper to demonstrate how you're looking to expand the project. Is it possible for the committee to have sight of that?
It will be, Chair. That's still going through some of the financial modelling that we need to do. So once that's all completed and we're presented that to CMB, I can then send through to yourself and you can share with the other councillors.
Okay, I appreciate that. Councillor Pocock?
Yes, thanks, Chair. Could you spell out a bit more detail, John, on the indicators? Just get the numbers right here. Numbers 12 to 15. These deal with the preparation for adulthood. I'm slightly confused about the numbers here, so just to be clear, it looks like the numbers are going up. The indicator 11. Numbers are satisfied with the transition plan, up from 46 to 62, and number 13, the numbers are satisfied they can achieve their outcomes, 63 to 24. So this seems to suggest to me there's a lot more volume coming through now. Is this right? Show the numbers rapidly. The next comment, which looks like a good comment, on indicator 14, it ends at 96.9%. Of those aged 14 to 30 feel they can achieve their outcomes. Can I just ask, not querying the outcome, it sounds like a positive one, but exactly how do we measure that? What question is it? It gives 96.9% saying yes.
Yeah, thank you, Councillor Pocock. So in relation to the transitions performance, what we always said is that we needed to spend some time because we had the proof of concept work that is continuing, and we need to spend some time to understand the metrics to surround that, and also in addition to that then the outcomes for our young people. There is a paper at the moment that we're working towards and will be taken through the appropriate governance, which then looks at the milestones and outcomes for the proof of concept and how we can then mainstream that work, which will also include bringing our social work teams very closely aligned to the vulnerable adult team, which is working with those that are 14 to 30, and the integrated transitions team, which is working with young people from 14 to 25. Both those teams work both across adult social care and the Children's Trust, and work very closely with then health and housing partners as well. When we looked at the capturing of the outcomes, which is what you've outlined with, in your question, we worked with the Youth Empowerment Squad, which is linked to the People for Public Services as a subgroup, and our young people helped us develop a questionnaire that we could then ask our citizens and also their carers when we were then working very close with them. And in addition to that, from the moment someone starts working with our team, we don't just look at what their needs are, we then start looking at what their aspirations and what outcomes they want to see from our intervention. We then measured ourselves on whether we have actually achieved those aspirations and outcomes. Where we have, that's where we then see the success and we're able to target that support. As a result of that, what we have seen is a number of young people that were then significantly far away from being able to employment, who have now got either into employment or started their own micro enterprise, and also those that have gone back into training and gone back to college. The impact, especially on the young people and the feedback we get from the Youth Empowerment Squad, is being the work we do is having significant impact on individuals and making a real difference to their life. What we need to see is from an adult social care point of view is how we can then mainstream and also increase the volume.
Just to be clear, if I can share, the question that produces a 96.7% yes is a questionnaire.
Yeah.
Is that a questionnaire? Is that done independently or is this then reported?
It's not done independently at the moment, Councillor Pocock. It's completed by the team, but there's no influence to that. So we send that to the individual and then it's sent back and we ask a number of poignant questions. I can have one of my colleagues send it across to Councillor Brown and share that with yourselves.
Thank you.
Yeah, that'd be really appreciated, John. It's like who was first?
Thank you, sir. Thank you. Thank you, Chair. It is John for clarification again. About the page 19, the shared lives, the occupational therapy commissioning colleagues as well as the national body shared lives class to support individual carers and the people they are care for and to build resilience in our community. So what kind of the support available from the shared lives to the to the carer and the patient and whatever it is. So do you understand my question?
Sorry, Councillor, it just broke up a little bit. If you could just repeat the last bit for me, please.
What I did the page 19 shared lives and the last paragraph, it is mentioned we are working collaboratively with occupational therapy commissioning colleagues as well as the national body shared life class to support individual carers and the people they care for and to build resilience in our community. So little bit of question, what kind of support available for the carer as well as for the the people those are getting the service?
So our Shared Lives carers, our teams and also Shared Lives Plus supporters with some of the national guidance in relation to Shared Lives. Our carers on the ground are supported in relation to training and also supervision, so we wrap around that support. When they have issues or any concerns, then our team step in and support that. So that may be in relation to us acting as a liaison with benefits, with housing, or even with health professionals to then make sure that our carers who take on the responsibility of being a Shared Lives carer are not left alone to deal with a lot of issues that they would. We ensure we wrap around that support in a way that engages with the carer, engages with the citizen, but also builds on that resilience of that individual to make the longevity of the placements possible.
Thank you.
Okay, thank you. That Councillor Allen.
Thank you, Chair. Just 2 points. How is it possible that we can improve? As I said, it shows what's happening, what we're doing, but it's the lack for me is the outcomes in the boxes, which is what I'm still feeling that I'm missing. So I can see this is the outcomes of what was happening, what we did, and here's the outcomes. And on a good note, I'd have to say that the reds, through you, Chair, that the reds have certainly dropped, and it's good to see the amount of greens that are increasing. So I can only add through you, Chair, compliments and thanks to all the teams that are involved that have helped to take the reds further down just to 2 at the moment and bringing the reds up to ambers up to just 3, but greens up to 8. So that's commendable and thank you, John. But it's just those outcomes I still need an answer to if I could, John.
Yeah.
Thank you.
Thank you, Councillor Fowler. I'll speak to Maria and we'll then make sure that we capture that and we'll be a bit more explicit within our update.
Thank you. Thank you, sir. I think Councillor Francis wants to ask something and then I need to, and then we are getting towards time, so we...
Okay, thank you. John, I was never very good at maths at school, and looking at the figures, I mean, I'm not asking you to add another column to the scorecard, but when I look at 91.3%, say for number 14, I don't actually know how many numbers we are talking about. Is that 91% of 10 people in a room? Is that 91% of 3,000 people? I can't quite get my head around what sort of figures we're talking about. So from a committee point of view, and only through the chair, I just wonder if we, on anything that's read, perhaps not every time, but have some snapshot of what actual figures we're talking about, because percentages can mean anything really. It depends on the number of people you're actually talking about.
That's true.
Yeah, we can work through that for you, Councillor Clancy. We can bring that into future reports.
I mean, I don't mind if it's one particular topic or something we're concerned about as a committee, and we take a number and say, look, okay, well, this is red, and we've looked at that, and that's sort of been red for a while. What sort of figures of people are we looking at?
Yeah.
Okay, thank you for that, John. My last question is going to be in terms of direct payments. You've got a notification down the direct payment challenge group that's looking at ways to increase the uptake of direct payments. I felt for an extended period, actually, the direct payment figure is not growing significantly. And I just wonder if you've actually reached a plateau now, and it's going to be really, really difficult to push that figure much further forward, possibly because of cultural or generational reluctance on people to actually take a direct payment up. Would I be right to actually to think that?
I believe that the 40% is, so 39-40% is where we should plateau, Councillor. When we look at it, Birmingham has one of the best direct payment rates in the country. And so that is testament to all the work that we've done. We're going to bring a paper to a future committee that is then linked to our citizens and the outcomes of direct payments. But we are very acutely aware that we've done extremely well, but we do believe that we can do better.
Councillor, do you want to come back? You sure? Okay, thank you. I suppose I understand, John, that the situation regarding direct payments would probably be replicated across the country. I just wonder, from my own personal experience, family-wise and work-wise, that there may be sort of a reluctance of some groups, certainly as you get older, actually not to want to take that responsibility of the direct payment. I'd rather somebody did it for me.
Yeah, and that is very true. What we see is some people embrace direct payments, really want to see the autonomy that they get using the system. Others are reluctant because they don't want to take on that role of the employer or the hiring of carers, and that's where our commissioning colleagues, our domiciliary and also other parts of our system then step in. So, and also what we have is some of our citizens that will both have a direct payment and also a commission service, depending on what they want to use their budget for. Our work that we're doing with our principal social worker is very much around how we can make sure that we keep supporting direct payment carers and also the direct payment process to make sure it promotes independence and also gives people choice and autonomy.
Okay, thank you for that. Does anybody else have any questions to answer? No? Okay. Thank you very much for that, John. It was just really illuminating, as always.
Yeah, thank you very much, Chair.
Thank you, John.
Thank you. Okay, now we've got Amanda Jones, who's going to begin the item on citizens involvement.
Good morning, everybody. Good morning. So I'm here today to introduce this session. I'm going to talk about citizens' experience of our early intervention system, concentrating this morning on our early intervention community team. So to introduce the systems, what I'll do, I've got a few slides, I'll go through them just to give you a bit of an overview, and then I'll come over to the citizens to talk about their experience. And thank you again to Chris and to Ruth for joining this morning. So if we can move to the slides, please.
We took that early intervention.
Yeah,
It was from this morning?
Yeah, it did come this morning, yeah.
Right.
Yeah. And I know we've referenced it earlier, so I'm really pleased to bring this to you today. So this is a very brief overview. Of course, if you want more detail in the future, happy to bring that back at your request, Chair. If we can move to the next slide, June.
That might be a bit of a problem at the moment. I'll just check whether that's any good. Excuse me for a moment.
Shall I pause the presentation?
For a moment,
Yeah.
please.
Is that okay now, Amanda?
Yes, that's great. Thanks, June. We'll just pause for a second.
No, that's fine. It's okay.
Okay, sorry. We resolved the problem in the slide.
Oh, is it okay, sorted?
Stepping in the.
Oh, right, sorry.
Should we proceed with?
Yeah. Thank you. So as a background to early intervention, in 2017, Birmingham Health and Social Care System set out to develop consistently safe and high quality services. This was in response to some feedback from CQC on performance around delayed transfers of care within hospital. So the system partners are Birmingham City Council, Birmingham Community Healthcare Trust and University Hospital Birmingham, and the whole programme reports into the Birmingham Integrated Care Programme. The aim is to look at support for systems that emerge from a health or social care crisis as independent from care as possible, and support where we can will be delivered in their own home. So the early intervention programme was developed to deliver an effective intermediate care offer, with the offer includes both home and bed-based support via a multidisciplinary integrated approach. Next slide, please. Thank you. So I won't go through too much detail here, but these are the different components that existed in the whole early intervention programme. So we've got OPAL there, the Older Pupils Assessment and Liaison Service, which is based at the A&E departments across the hospitals. And the aim there is a multidisciplinary team to work with people as they come through the front door to see if we can get them back home and avoid hospital admission, or to provide some support at that point. We also have our early intervention community team, which is what I'm here to talk about today, is at the centre of all of these things. I'll go into a bit more detail on that shortly. We have our early intervention beds programme, which is for people who may require short-term placement to support hospital discharge or avoid hospital admission. And then we have our iHub, which is a new function, which is around decision making for hospital discharge pathways. And we have a mental health aspect as well, because we recognise that up to 50% of people, older people, are actually in mental health units for an unnecessary long length of time. So there's a particular work stream looking at how to develop their support for that group of people. Go to the next slide, please. So here is a short clip around what does early intervention mean in practice. It's a couple of animated case examples. So I'll just ask June to play that if you could.
I think it's
Sound.
I'm just putting the sound on.
Introducing Early Intervention, a new integrated approach to health and social care for Birmingham. 7 health and social care organisations have combined forces to deliver early intervention to the 1 million plus population of the city. Working towards 4 key goals, its aim is to provide the right care in the right place at the right time, with a home first ethos. The programme is also playing an integral role in Birmingham's response to the coronavirus pandemic. The unified approach focuses on 5 areas of health and social care: And this is how it works in practice. Meet Abdul. He's 75 and lives in Birmingham. He was admitted to hospital after suffering a seizure. After a week, the new early intervention multidisciplinary team within the hospital's discharge hub agreed that he was well enough to transfer to a community hospital to continue his recovery. After 5 days there, he was discharged with support from the early intervention community team who would continue to care for him at home. A member of the community team visited Abdul at home to assess his needs and record his details on a central system so he wouldn't need to repeat himself again. At the daily multidisciplinary team meeting, the community team reviewed Abdul's notes and agreed that along with physio support, he would benefit from rehabilitation assistance to get him walking again. A physiotherapist and a rehabilitation assistant visited him twice a week, and within 4 weeks, he was walking again without support. Thanks to the new early intervention approach, Abdul received the right care at the right time in the right place. His stay in the acute and community hospital was kept to a minimum, and he was able to continue his recovery at home. Now meet Alice. She's 82. One day she tripped, fell, and couldn't get back up on her feet. After hearing her calls for help, her neighbour dialed 999. On arrival, the ambulance crew decided she should be admitted to hospital for x-rays. After no fractures were found, the older person's assessment and liaison team, known as Opal, assessed Alice. Opal uses the combined expertise of a multidisciplinary team led by a geriatrician to ensure older people get the right ongoing care and avoid unnecessary hospital admissions. Opal discharged Alice home with a referral to the early intervention community team to help her with her balance issues, anxiety and depression. The next day, a social worker from the community team visited her to carry out a full assessment. The wider team reviewed her notes at its daily meeting and developed a 4-week recovery care package for her. Alice was visited by a nurse and physio regularly to improve her mobility and safety at home. For her loneliness, the team put Age UK in touch with her, and a mental health nurse also worked with her to help reduce her anxiety and depression. After a month, Alice became more steady on her feet, her mental health improved, and she began enjoying time with friends again. The new early intervention approach helped to ensure that Alice wasn't unnecessarily admitted to hospital and that she received the right ongoing care to enable her to recover at home and regain her independence. She received truly integrated health and social care. More than 1,000 staff are now delivering the early intervention programme across the city, helping to transform the delivery of health and social care in Birmingham. The city's health and social care system remains united in its goals, working together to make Birmingham a great place to grow old in. Introduce.
So I've included this slide just so you can see the spread of the early intervention community services across the city. Early intervention community team are based in 5 care centres, one in each of the 5 localities as here and there, serving population transit. So I thought it was helpful the illustration of how that spread is illustrated there. Next slide, please. So the early intervention you heard about in the animated case studies there. So we went live in 2020 across 5 localities citywide. The aim is to proactively avoid unnecessary and avoid those hospital issues we heard about there. So we're supporting people as soon as possible and keeping them at home as independent as possible. And within the early intervention community team, we provide therapy and personal care services to wrap things around people at home to support the development of their skills and maximise their performance to perform everyday tasks as independently as possible. Next slide, please. So the support is happening in people's own home, and the early intervention community team actually is at the centre of all the other teams that I described earlier. So they are working across the whole system, And there is a truly integrated approach. So the team, in each locality will include nursing, therapy, social care and reablement assistance alongside a domiciliary care offer to support that person, whatever that support might look like. And it is recorded on one system, so the person's telling their story once. So again, just repeat that story about the right professional at the right time, giving the right approach. So a service for somebody in the early interventions community team would generally include a therapy element, a therapy assessment, and also reablement support, personal care if it's required to deliver care at home, and an assessment from a social worker to see if there's any long-term health needs that are required. And that assessment from the social worker is very much within the 3 conversations model that we touched on earlier. So it's the keeping within the principles of everything else that we're working within the health and adult social care system. So the support is short term, so there is usually between 4 to 6 weeks that somebody will be supported in early intervention. Some people it can be less, some people it can be more, so we don't have a fixed figure on that. It depends on the needs and the therapy goals identified. But at the end of that, if they require long-term support, citizens are put in touch with long-term services and that work continues in the community. The support is available across 7 days a week, and we also provide a 2-hour urgent response in the community. For working closely with West Midlands Ambulance Service. We also have a pathway within early intervention community teams to support those who can't return home for reasons such as hoarding, quality of the accommodation, by the deep clean, or those who are homeless. So we have a temporary accommodation provision, which includes housing support, which is wrapped around them alongside the early intervention community team to get them back to where they need to be. Next slide, please. Some feedback here, and I won't go through all of the feedback because we actually have some citizens on that can speak to you, but I've included this because it's something that we've got a spotlight on in our regular newsletter, so it's there for your information. Next slide, please. And then the results, and you can see the timeline there, it's from March 2020 to July 2021. So we've saved around 90,000 acute bed days annually. It's 45% more likely for people to go home when leaving those non-acute beds. Those are the short-term placements that we have in the community when people need a short-term residential stay. More people are now going home than previously by 45%. Usually we had seen the majority of people going on to long-term care residential placements. So we are doing more work in that area because we feel that we want to get more people home as much as we can. We have also avoided over 15,000 admissions to hospital, and we've reduced ongoing care needs from a social care perspective to 6.7 hours a week from what it was previously. And we've reduced the length of stay in the acute services from 12 days to 3.4. Thanks, Jean. Okay, so we've got a couple of citizens on the line, and also there's a couple of quotes there from people who wanted to come this morning, but because of other reasons have not been able to. So June has included some feedback there, and it is pretty small, but I'll try and read it. So Mom would like to say that the care she received is very good, and then the second one, it helped Gerard's mental health, him going for fresh air and doing shopping with help from staff taking him. So I could talk a bit about those cases if you want more information about the verbal feedback there, but I'd really like to hand over to my colleague June, who's on team supporting our citizens, so you can hear directly from there. Sorry, June, you're on mute.
I've got 2 mute buttons, I'm sorry. Thank you, Amanda, and thank you, everybody. Good morning, and thanks for having us attend today. I'm really pleased to be able to introduce you to both Chris and Ruth, who we've had lots of email communication with and phone conversations with, who have both voluntarily agreed to come and talk to the committee about their experiences as a carer of somebody in receipt of services from the early intervention service. So if it's okay with you both, Chris, shall we start with you first, if that's okay?
Yeah, no problem.
Great. Well, should we start off? Do you want to introduce yourself, Chris, and just tell the committee who you sort of care for and why we've asked you to come along?
Yeah, hi, my name's Chris. My wife was diagnosed with early onset Alzheimer's in 2015 at the age of 56. So things have obviously just progressively got worse and worse. At the beginning of August, a sister came over to pick her up one Sunday morning, and she was just, she wasn't a normal self. She seemed to be hallucinating. So her sister took her round to a friend who's a nurse, and then the nurse seemed to think she possibly had a urine infection. So they went straight up to A&E. Everything turned out to be okay. But the Opal team got involved. On the Monday morning, by about 11 o'clock, we had a visit from somebody from the early intervention team. She sat with us for a good hour and a half, talking through lots of different things, come to the conclusion that we needed somebody to come in every morning to look after my wife, help her get dressed and bathed. That literally started the next day. Unfortunately, it wasn't very suitable. The girl that was coming in was very, very young, very, in my eyes, very inexperienced, and it just caused my wife to get more and more upset every morning. So I basically told them to stop coming on the Friday. On the following Monday, I got back in touch with the lady who I'd been dealing with at the early intervention team, and she started sending in what I believe is your staff. All the women, I must admit, were in excess of 40 years old. They all seemed to be a heck of a lot more experienced than the young girl that had been coming in from the company that you seem to deal with. I mean, am I allowed to mention the name of the company?
Yeah, absolutely. It's you telling us about your experiences.
It sounds as though you basically, as soon as you go into default mode, you just send people in from this company called Servacare. In my eyes, I've had dealings with them in the past with my mother. I don't think they're the best company in the world. I don't know why you decide to palm this service out to somebody else when you've obviously got staff that you can use. It'd be better if it was in-house, personally, from my view. So we had 10 or 15 days of your staff coming in and everything was fine. My wife was absolutely brilliant every morning when the girls were coming in. I think over a 15-day period, we only had two visits from the same person. So we had lots of different people, but because of their age and their experience, it put my wife at ease. Since then, we had a visit from the social carer. She was absolutely brilliant as well, Teresa. She came in, she spent a good hour and a half with us going through loads of different things that we needed to do and didn't know. And she just put me at ease. She was constantly phoning me to make sure everything was okay. She then phoned me when everything was being handed over from the council to a care company, which is Nationwide Care Services. Since we've been having them, everything's been absolutely fine. The girls that are coming in are basically over 30 years old, which is putting my wife at ease because we've never had children. So I think she just feels more and more comfortable with older people. I mean, she's only 63 herself, bless her, but it's been working well. Everything seems to have slotted into place well. And I just thought, somebody needs to have a pat on the back. So that's why I sent the email off.
So, Chris, thank you ever such a lot for that. It sounds like you've had some really good and bad experiences, but mainly good, which I'm delighted to hear about. Just before we move off, is there anything else you want to tell us that we could do better? It sounds like communication was really good with you from the early intervention team and yourself in order to make sure that we fully supported your wife. Is there anything more that you'd like to see improved or anything you'd like to see, us do differently?
Well, apart from the fact that I don't think you should be using one particular company, I think you ought to take the staff on and get your own staff involved rather than just palming it out to people that, these care companies, some of them are good, some of them are not brilliant. Why are you wasting money on them when you could be generating a really good skill set for yourselves by keeping staff and just using your own people?
Perfect. Thank you, Chris. Don't go anywhere. Okay. Chair, if it's okay with you, I'd like to just invite Ruth to chat to us about her experiences in case anybody in the room would like to ask any questions to either one of our lovely carers after she's presented, if that's okay.
That's fine. Yes, carry on.
Thank you. So Ruth, hello.
Hiya,
Thank
right.
you very much for attending today. Really grateful of you both to give us your valuable time. Do you want to introduce yourself first to the committee?
Yeah, sure. I'm Ruth. I've been caring for my mum and my dad, but mum's the person who's had the care access. So yeah, she lives quite a way away. I've got two other siblings who live quite a distance from them, so I've ended up helping them myself, work full time, got 3 children, so it's not as much as I'd like, and it's not as much as they needed. Mum needed a hip operation. She's had it cancelled before COVID a couple of times, then during COVID another 3 times, and she basically deteriorated due to that. That's the root cause of it. It got to a point where she was delirious. She was on morphine that didn't seem to be touching the base. Her mental health went down, her physical health went down. She lost all muscle mass. My dad was doing the lion's share of stuff, obviously. He's not the most patient man in the world, and his mental health went down considerably. And it all reached a head where mum was in bed. We got called round. She was in a complete state. Dad wasn't capable, and they've got quite a traditional marriage, and he wasn't going to be doing her personal care. He wasn't capable, and it just wasn't going to happen. So we muddled through the best we could until that moment where it all went up in the air. And I've got to say, from then, I mentioned to Dad I was speaking to you today, and he said, tell them they're absolutely brilliant, because it really did save them both. Mum would have definitely ended up in hospital. She was in a complete state. Within a matter of days, I couldn't tell you specifics, but it happened so quickly that she was moved. A hospital bed was put in, commode was put in, carers were coming to help her with her physical needs. And she improved quite a bit from those things. Just being able to be downstairs and have company and hear the TV on the go and have people come in and just break up the days as well, and for somebody for them both to talk to.
Ruth,
So,
can I just ask you before, how did you obviously came to a crisis point, unfortunately, with your mum. How did all of those services get put in? Did you contact your GP? Did you contact
the paramedics were called. I wasn't there at the time. It was my dad and my sister, and they called the paramedics because she wasn't with us at all. She was in a terrible state, and they didn't know what to do. So they rang the paramedics, who rang the carers. So by the time I got there was about 6 different professionals in the house. And everything kicked in really quickly. The hospital bed downstairs, the doctor came and did house visits, which was like getting hen's teeth before. And it all kicked in from there, basically. The carers came, silly things like they washed her hair, and she hadn't been able to have, feel fresh for such a long time. Yeah. Brilliant. She had to go. She did have to end up doing a life savings to get a hip operation, despite it being cancelled by the Priory through the NHS. She then went and paid private, and the Priory then would look at her. So she got it done. We've moved her into a single flat, and she stayed out of hospital. From my own opinion, if she'd have had a hip done in the first place, it probably wouldn't have cost as much as the amount of care required.
And was that delayed because of COVID, do you think, or was that before COVID?
It was delayed a couple of times before COVID. There was a problem with the heart. Another surgeon said she would still be fine to have the operation. Somebody says she couldn't. And by the time he got to it, the Priory would do it. So they paid what they got and got it done.
And I'd ask you the same question as I asked Chris earlier. Is there anything you'd like? It sounds like, the service was really quick. The provision put in and the support for your parents was really done very quickly. Is there anything you'd like to see improve with the service? Is there anything we could do better, worse? What are the good and bad bits, if you like?
In regard to the early intervention team, nothing. The only complaint my dad had was when the carers left, they put their PPE. They just dumped it about, basically, and neighbours complained because There was PPE outside the house. Other neighbours were coming out and cleaning it up. Not nice, especially when Mum had got no control over certain things. It wasn't pleasant for us, let alone having it in the street and the neighbours having to cope with that. So that is the only complaint at all. The early intervention team, absolutely brilliant. It's just a shame all that money got spent through the early intervention team where he could have been nipped in the bud in the first place, and none of that would have had to have kicked in.
Great. Thank you, Ruth, so much. And thank you, Chris, for being so honest. Chair, I don't know if there is any questions in the room or any questions to our two lovely carers that have been able to join us.
First, I wanted to sort of repeat effectively what you just said to Chris and Ruth. I really appreciate your time and your honesty and candour here. It really has been very valuable to me, and I expect so to other members as well. So, open the floor to members in terms of any particular questions you want to ask. Okay,
so, thank you, Chair. Thank you, Chris and Ruth. Chris, first of all, with the company that you have mentioned, I guess that's when and if we use outside, when you get people like Chris and others that identify issues and problems, it's then, I think, for us to discuss with that company, these are the issues, problems that have been brought to us by people that you are helping, and what improvements can be made within that organisation. And I think, Chris, if that doesn't happen, then it's time to say kind of hopefully goodbye to that company, because they are not what I would say fit for purpose if they're not able to improve the problems that people like yourself and others identify. And with Ruth, it just shows you, Ruth, the problems that this pandemic has caused, both in hospitals with beds and people not being able to go and get their surgery, or they're then, as we do like with early interventions, to be at home so they're around family and their community. And it's good that people get the help at home. And I have to say, from a personal note, that my mother, Chair, suffered a stroke 3 years ago. She passed away 2 years ago. But we had a company who was private. This was from Coventry, but the help that she had was good in parts and not so good in other parts. And it kind of goes back to the bit with Chris. So you do get companies, you get in-house, can be very good, can be a few problems, but you can actually get outside companies. And I have had the feeling that sometimes it's money that counts. The staff do work hard, but they don't get, I feel, the support from some private companies. In other words, I think they need to look at themselves and see how they can improve themselves before potentially, like probably Coventry and Birmingham, they kind of should be kicked out the door. Thank you.
Can you ask any questions?
Yeah, well, I'd like to ask both Chris and Ruth, also thanks very much for being open and honest with us about your experience, warts and all. We've got this new team now, early intervention. When you talk to friends, family, relatives, neighbours, do you think people know about this new style of service? How much are they aware of this new way of working? Because I was keen to know whether it works, and if it does work, to get the message out. And I think Ruth's point that a stitch in time saves 9, I think, was what my mum always used to say. Your experience, I think, is very much of that sort. How we can get in early and stop the problems before they get out of hand. So I'm just interested if you picked up on your conversations with people as to how aware people are around and about as to this new way of working.
Ruth, do you want to respond first?
Sorry, I missed the end of that.
Right. So what the councillor was asking, Councillor Pocock was just asking was, and please correct me if I've got it wrong, Councillor Pocock, it's June here, was just to say, you know, you've obviously talked about your experiences of working with the early intervention service and how good they were. Do you think your friends, relatives, neighbours, etc., are aware of the support on offer? And you know,
we hadn't got a clue, and I don't think unless I've spoken to people about the early intervention team, and even then, they might not know the different situations where we could kick in. I don't think it's well known at all that you're out there. It should be. I think you'd have an influx and you'd have a big job on your hands. But if you could replicate the experience we've had with Mum, because I'm pretty sure it saved Mum's life, and it definitely had a huge impact on Dad's. I think a lot of people had come forward for that help.
Thank you. Chris, would you like to add anything?
Yeah, I'd never heard of it before, and everybody I've told the story about what's happened with, because it has turned things around with Jane. The other thing that I did forget to mention was when the early intervention team did get involved, they also got the memory clinic involved on Reservoir Court, where Jane has to go and see a specialist every 6 months. And by the Wednesday, we had a visit from a member of staff at the Reservoir Court, and they decided to give Jane some extra medication, which I must admit, in the space of a 3-week period, has turned her from being delusional into constantly walking around with a big smile on her face. She's a changed woman. Everybody in the family cannot get their heads around the fact that she's changed so much, and they're so grateful that what happened, even though it was a horrible thing that happened on that Sunday morning, we wouldn't have known about the early intervention team. If that hadn't have happened, we would have still been struggling and carrying on, and Jane would have still been in the state that she was in at the beginning of August. So it's not generally known, and unless you actually get involved, I think then that's the only time that you find out about it.
And that's when you've hit crisis point.
Exactly, Ruth.
Thank you. Does that answer your questions, Councillor Pocock?
Very good, thanks.
Thank you.
Okay, can I ask a question, Mr. This is to Chris and Ruth. Obviously, with the early intervention community team, it's very much an integrated approach. So you've got a number of professional people that would have acted potentially separately before, all working together as one. How did you actually find that assisted you in your role as carers, in terms of really taking pressure off yourselves, in terms of, no, I've got a team here that are going to pull this package together, rather than I've got to respond to each individual services directly? Did that make a difference? Errors.
Ruth, you going first?
Sorry, for me, it was huge because obviously for Chris is there 24/7. For me, I've still juggling having my own family, and it's with my mum and dad. But it took a lot of pressure off me to be able to continue to carry on work, look after my own children, my own family, and still be able to get there to sort out the other needs that hadn't been met, like getting their shopping and that kind of thing. So it felt like I'd got somebody to hold my hand as well. So it took a lot of pressure off me, definitely. And at the point where you kicked in, I couldn't have carried on juggling. It was affecting my family life as well.
Great. Thank you, Ruth.
Thank you for being so honest in your response. I really appreciate that.
Yeah, Chris, do you want to add anything?
No, it's just the fact that once it kicks in, it just opens your eyes. You don't realise what is available until you hit crisis point, and I think that's the big problem. Everybody's just keeps going, and all of a sudden something snaps, and then all of a sudden everybody sort of appears out of the forest, and it's like, oh, we're here to help, we're here to do this. And it's just one person after another just seems to appear in your life, and you've had all this help from nowhere, but it took till crisis point before it actually happened and kicked in. That's the worry.
Thank you.
Okay. Right, anybody else have any questions for Chris and Ruth? Okay, well, thank you very much for joining us. We really appreciate it. And as I said, I personally appreciated your honesty on what in the comments you've actually said and the way you've answered questions. So thank you.
No problem.
Before you go, do you think?
Sorry?
It's breaking up, Councillor.
Us.
Still breaking up.
Yeah. Oh,
Are there any questions you'd like to ask the committee or any closing thoughts you'd like to give us?
there you go. Who wants to go first? Ruth.
Sorry, just putting in Chris, sorry.
It's all right, Ruth.
My only thing, just point was, Jane's really lucky to have Chris. I'd hope to think Mum's lucky that she's got me and my dad, but it's scary to think of the individuals out there that haven't got anybody, because their crisis point, there's nobody who's going to pick up the phone like we did. So it's for, yeah, I think more needs to be out there for people who haven't got anybody. I don't know how you get to it, but yeah.
Thanks, Ruth.
I fully agree with what Ruth said there. It is down to the fact that she's obviously there for her parents. I'm here for my wife. But it's like, what happens if something happens to somebody who hasn't got some support? And the other thing I would like to say is, if you think me and Ruth are being a little bit friendly, we do actually know each other. And we've known each other for a long, long time.
Good.
And it's just very coincidental that we both turned up at the same time for this thing.
Yeah.
Great.
It's been about 10 years.
Yeah.
Okay, thank you very much for that. So, has there been any questions for Amanda?
Thank you both.
No
Thank
problem.
A couple of comments actually, Amanda. I'm looking at this. I was quite impressed. I like your approach. I like the iHub, and it just shows, because Councillor Perkett and I were involved in hearing about this some time ago. We could see the ownership taken up by the team, and I suppose in officer speak, it certainly is, and shows you the golden thread that goes through, which is crucial because it stems to every bit of part with all the services that are there to help from A to Z. And I certainly like this early intervention across Birmingham with the 5 localities. And again, that's the great comfort they're in that one area. And I think, Rob, we actually praised that a long time ago on that, and certainly welcome the support that's on offer. And again, it's good that you're getting some public feedback, and again, outcomes that they've received so far from it. And I think that the one thing that Chris picked up on, and so you Chair, be interested from Amanda, what is now being put out in the form of communication to excuse me, social media by councillors, obviously advertising, posters and leaflets, whatever, in all health hospitals, etc. Because Chris said that, as Michael Perry, a lot of people know that. So yeah, it does need to. It's a new and fresh, but certainly the getting experiences are praised from a couple of people there, and I'm sure, Chair, there's more out there. But all in all, it's very much welcomed. And finally, I think it was page 9, and I know that Rob must have been pleased to see this. The results: 90,000 acute beds saved annually, 15,000 admissions avoided, and so on and so forth. That has got to be fantastic for everybody. So even though it's still in its infancy, so to speak, through you, Chair, congratulations to all those involved, because the proof is there. Thank you, Chair.
Thank you for those comments, Councillor Pocock.
Yes, thanks, Chair. 2 points. First of all, congratulations to Amanda and to the team that you work with. I think this is a first for this committee, and maybe right or wrong there, to get voice of the citizen into the room where we hold scrutiny. It's a really important precedent, and I know I attribute it to Councillor Miller, who raised this point when we had a discussion about the enablement workers, we had the workforce and officers, etc. I think your point was, let's hear from the service users. We have got a mechanism now, thanks to the team we've put together, to feed directly into the views of service users. It's an important precedent. I've said this to officers I think we should apply this more across the whole of the scrutiny operation to allow the citizens to help us to understand how the people of the city are receiving the services. So it's a comment and a congratulations. I think we've got to this point. Secondly, Councillor Fowler made this point about the slide on results. I'm really interested in this. I don't like to lose everything to money, but just as a random thought here, I think it's hospital bed is £300 a day thereabouts. So in saving terms, you save 2.7 million in that one step alone. I think it would be good for the bin counters on the money to say what is it we've saved through this intervention that would otherwise have been a cash burden to the health and social care services. This is an intervention that improves care and saves money. And I think that big message is a really powerful one. And if you could come back to another point, maybe with some attempt to put some cash onto this, I think it would be very helpful. And also, I'm not questioning the figures that you have in. I'm sure they're honest, but how you come to these figures, the committee that likes to understand the detail, so to verify the evidence you've given to us, I think would be very helpful.
Okay, thank you. Before I bring councillors on, I just wanted to reinforce what Rob was saying. I think it's about saving money, but for me, the important thing is it's an improved quality of life for the service user. That's the crux issue. So, councillors.
Oh, thank you, Chair. Because I read this report this morning and I really very, very delighted, especially when I read the feedback from the clients. It is really very impressive and I'm really happy to see this report. I wish that this kind of activities will go on forever. Thank you.
Okay. Anyone else got questions? Okay. Can I just ask one myself then? It's a short-term service initially. What percentage of people require to go on to long-term support and what percentage of people are able to resume their previous life? You able to give me that, give us those figures or offhand or not?
I think it fluctuates depending on different times. So it could, I could pluck a figure out there, but I won't do that. I can give you
send that
information.
That would be appreciated.
Yeah, what we do know is that even those people who go on to require that long-term care, the amount of hours that they require has been reduced compared to what they may have done if they hadn't had the early intervention community team. But it isn't all just about adult social care packages that's put in place as well. It could be that there's ongoing therapy needs in the community that people access without a care package. So it's it can be quite a mixed picture because we offer that holistic support to the person.
Right, then the second one, obviously you produced a report's feedback in terms of, say for example, 15,000 emissions avoided. Did you have a benchmark figure in terms of the target that you were looking at, or did you not set yourself benchmark targets?
So we had the support of Newton Europe to look at diagnostics prior to the early intervention team going live. So they looked at in 2017, 2018 what our system looked like. And they did set us with us some targets. And for example, the target for the length of stay in hospitals was to be reduced from 12 days to 8 days. So we've well surpassed that and we're around 3.4 days. But I think we need to acknowledge that the time that diagnostic was taking place, it was pre-COVID. We're in a very different position. We've had to move at pace to mobilise these services to enable the pandemic response to be as effective as possible. And so we recognise that the targets that perhaps we set at the beginning are not really what we would be looking at now. And we need to revisit those targets and be a bit more ambitious about what we want to do. Because although these are good results, we feel that the system improvements, and we do not have an improvement cycle that we implement in each of those areas, take on the feedback and look at performance. We feel that there's more that we can add. So that work is ongoing, and we've launched phase 2 of the early intervention programme to look at what now. So that would incorporate a 2-hour response, strengthening that response, the things about getting it out there in the community and people knowing about it, the links with the GPs being strengthened, etc. That is further development work that we want to do.
Be cheeky and ask a further follow-on question then. In terms of information flowing down from hospitals, etc., how aware do you think GPs are as a general rule of thumb in terms of that this scheme actually exists?
So I think it's fair to say it's probably a mixed engagement around that, depending on GP practices and capacity within those practices. We are doing a specific piece of work linked to care homes around admission avoidance and GP surgeries and getting out there we had our iPod go on tour to do some rounds to promote the work that we're doing. So I think there is a bit of a mixed package. There's probably more we could do around awareness and engagement in that area. And I think the pandemic hasn't necessarily helped that because we've not been able to engage with our GP colleagues in the way that we perhaps would have done ordinarily, because I think it's been more virtual.
Okay, thank you. Any more questions?
Just to add, Chair, if I may, I've talked about, Chair, is about the promotion communications of it, and that actually links them to, because I knew that he would, as we both have done, is about the performance and the cost saving, as Rob has mentioned, 2.7 million to national health, and I would hope that further promotion and awareness of this would help to increase that even further, which at the end of the day is what it's all about. And as Chris actually said, that there are people that he knows, but equally there's lots of people out there that are maybe on their own, but don't know about this, but I'm sure and would hope that if something did happen to that person, then there is that, again, that golden thread and that link. This is the service that we know that we can provide when it goes to assessment. So very much is that I'm very keen to see how the communication is improved on this. So both health and public awareness is there, and know that it's out there for them, and know that it is there, and people are there ready and waiting. And God forbid, should something happen that may necessitate them needing that service. And thank you.
Okay, thank you. If there's no more questions, first, thank you for coming. Thank you for the report, which I think has been really valuable. And could you give the committee's thanks to Chris and Ruth? I think their comments have been really appreciated by everyone.
I will do. Thank you.
Okay, thank you very much.
Thank you. Thank you.
So we come now to the work programme for September, and I understand that the Birmingham Sandwell job is now rescheduled for the 14th. So that they've sent through an email for a potential backup date for that. If it's required, I think they're hoping to go ahead on the 14th. Do we have any comments, members, on the actual work programme that we've got set up? No. Okay, that's great. Do you have any requests for calling, council actions or petitions received?
We haven't received any, Chair.
Okay. Then the next bit is the other urgent business, and that's effectively to inform members, in case you hadn't noticed, that I've replaced Councillor Sullivan on the committee and I've replaced Rob as chair. And to say that the membership of the joint tasks will be, I'll replace Rob on the Birmingham and Sandwell joint task and replace Councillor Solomon on the Birmingham and Solihull joint task, and we'll replace Rob as joint chair of that committee. Okay. And the final point is to ask members to have the authority to act in between our next meeting.
Chair, I just wanted to, while you were steal the thunder, but while you were on a roll, again, my congratulations to you as taking over the chair. Although my apologies to Rob, I suddenly realised that I hadn't actually sent him and that I meant what I said in my email. And just thinking, it was after 11 o'clock, I was a bit tired, and I suddenly realised I hadn't finished off the email, so I had to get back in this morning. Because we did it. Sorry?
Would you like me to read it out now?
Oh, you can if you want to, I don't mind. It was just, I thought it was a bit ironic at the start on one comment that you made, but I did put joking apart this morning. And Rob, I do remember what I said. I'd like to thank you for your chairmanship of the Review and Scrutiny Committee. And Rob, we've worked on a number of issues such as the early intervention, period poverty, and coming up next month, infant mortality. And and I think we will hopefully see each other on the BMI and other bodies. And I think as a whole, and to be fair, the chair has often said to me, on the whole, we keep politics at the front door, and quite rightly, it's about the people, and that's the way it should be. So, Rob, for me personally, although new chair, you will be sad and missed on this, and I think we did some great work together, and I'm sure the other bodies will continue to do that. So thank you, Rob.
You're getting messy, Rob. Thanks for the positive comments. I've enjoyed the time as chair. And we'll see what happens in the future. It's a shame elections get in the way. Good work of scrutiny. So hopefully we'll get our way through 222 and we can carry on being an effective committee.
Okay, so unless anything else needs to ask members, have we got authority to ask?
Yeah.
I mean, it's quite an urgent situation between meetings. And thank you everyone for your time. I look forward to seeing you again in October.
Thank you.